Hello to everyone. Today I present our clinical data 2 experience. Distinct phase of adenosine deaminase 2 deficiency from mild to severe. Deficiency of adenosine data 2 is an autosomal recessive disorder characterized by polyarteritis nodosa, like symptoms, fever, livedoid rhizomosa, early onset stroke, and mild immunodeficiency. The loss of function mutations in CECR1 gene, which encodes the enzymatic protein ADA2 associated with DATA2. DATA2 is present with spectrum of vascular and inflammatory phenotypes with highly varied clinical expression. The patients can present with related constitutional symptoms, arthralgia, myalgia, or livedoid rash. The severe phenotype of the disease is emerged as early onset stroke, bone marrow suppression, neutropenia, liver failure, or neurologic disorders. It's currently not well understood what caused the variability in the severity of the clinical phenotype. We aim to describe clinical characteristics, genotype, and treatment of patients diagnosed with DATA2 in our clinic. We classified the patients to their severity of clinical manifestations, and we will present the distinct phase of the disease. All the patients diagnosed and followed up in Department of Pediatric Rheumatology, Ümraniye Training and Research Hospital, Istanbul, Turkey, between 2016 and between 2020. All symptomatic patients suspected with DATA2 were analyzed by genetic test and the DATA2 enzyme activity. Also, relatives of index cases were also screened. DATA2 enzyme activity was evaluated by Dr. Michael Hirschfeld in his own laboratories at Duke University Medical Center. Demographic, clinical, laboratory characteristics, and treatments of all patients were recorded. We diagnosed 10 patients with DATA2. 5 of them had mild phenotype and other 5 had severe phenotype. 3 of the patients were girls and 7 were boys. The age of the patients at diagnosis was in the range of 2 to 28 years. The age of the patients at disease symptom onset was also in the range of 2 months and 14 years. 6 of the patients were index cases and the other 4 were their relatives. Homozygous mutations in CECR1 were shown in all patients. I'll also tell in the tables later. The frequency of the phenotypic manifestations of the patients were seen as follows: fever in 80%, livedoid rash in 70%, digital ulcers and amputations in 20%, neurologic involvement in 50%, gastrointestinal involvement in 20%, hematologic involvement in 40%, and immunodeficiency in 30% of the patients. The 6 of the index cases preliminary initial diagnosis were 2 of them diagnosed with preliminary classical PAN, 1 cutaneous PAN, 1 Behçet's disease, and 2 of them were Diamond-Blackfan syndrome. The activity of ADA2 was evaluated and clearly diminished in all patients between the range to 0 to 12. 6 of the patients were treated with anti-tumor necrosis factor therapies. 2 patients were awaiting bone marrow transplantation. We showed G47R missense mutation in here in 6 of the patients, and S291L missense mutation in 2 patients, and Y453C missense mutation in 2 of the patients. We show 3 different mutations in 10 patients in 5 different families. The first table is present the patients with the mild phenotype. We see here 3 different family. The patients 1 and 2 with the same family, they present with the livedoid rash and the mild mental retardation, and also they have failure to thrive, myalgia, arthralgia. These patients present with the clinical mild phenotype, but their ADA2 enzyme activity was found 0. The patient 3 are in different family, and patients 3 and 4 are in different family. Patient 3 was index case, and patients 4 are the brother of patient 3. Patient 3 present with the livedoid reticularis and arthralgia, arthritis, and splenomegaly. The brother of his is only had livedoid rash. Patient 5 present with Behçet's disease manifestations, recurrent panniculitis and oral aphthous ulcers, and we showed in these patients also homozygous mutations in CECR1. Table 2 show the patients with the severe phenotype. The patients 6 and 7 are the same family. Patients 8 is member of the family 1. The 2 brothers are in the table 1, and their mild phenotype, but these patients, sister of them had severe phenotype, and patient 9 and 10 are only present with the Diamond-Blackfan syndrome and hyperimmunoglobulin M syndrome findings, manifestation. Family 4, patients 6 and 7 had a severe mucocutaneous involvement and severe neurologic involvement, and their ADA2 enzyme activity was found 0 also. Patient 6 and patients 8 were different clinical manifestations also. Severe gastrointestinal involvement. Patients 6 had intestinal perforation and aneurysm in the celiac trunks. We presented here in the phenotype and treatments of 10 patients with ADA2. The clinical manifestations of ADA2 vary from mild skin involvement to severe multisystemic vasculitis. 5 of our patients were presented with mild, moderate phenotype, and other 5 were the severe phenotype. We confirmed the diagnosis with ADA2 enzyme activity, and it was decreased in all these patients regardless of the severity of phenotype. Digital ulcers, amputations, and central nervous system involvement occurred predominantly in the patient group with lowest ADA2 activity levels. It suggested that residual ADA2 activity levels are important in clinical phenotype. We observed significant clinical heterogeneity within this case series, even if carrying same variant. This suggests additional factors other than the CECR1 mutations, such as residual enzyme activity and epigenetic factors, are important in determining clinical course. In conclusion, the presence of familial vasculitis, early onset stroke, parietal consanguinity, or presence of similar symptoms in family, unresponsiveness to conventional therapies in patients with predominant diagnosis of Behçet disease, PAN, or early onset PAN-like disease should be aware to the physician for considering ADA2 and order a genetic examination, ADA2 enzyme activity. Further research is necessary to elucidate other factors determining the clinical course. Thank you for your attention.